My name is Lindsay Miller. I'm a volunteer, and I'll be helping to moderate today's session, which is Systemic Treatments for Radioactive Iodine-Refractory Papillary, Follicular, and Hürthle cell thyroid cancer. Our presenter today will be Dr. Sukrithan, a medical oncologist and assistant professor in the Division of Medical Oncology at Ohio State University Comprehensive Cancer Center in Columbus, Ohio. Dr. Sukrithan is a member of the Translational Therapeutics Program at the OSU CCC and the co-director of the Adrenal Tumor Clinic. He was recently selected to lead an externally funded effort through the International Thyroid Oncology Group to operationalize a multi-institutional registry database for patients with medullary thyroid cancer. So thank you all for joining us. Thank you all for being here, and I'll turn it over to you, Doctor.
Thank you, Lindsay. Appreciate the introduction. So good afternoon, everyone. The title of my presentation is Systemic Treatments for Radioactive Iodine-Refractory Papillary, Follicular, and Hürthle cell thyroid cancer. And I'm titled the presentation, A Journey Down the Yellow Brick Road, just to keep things a little bit interesting. So by way of introduction, my name is Vineeth Sukrithan. I'm an assistant professor of medicine in the Division of Medical Oncology at Ohio State University Comprehensive Cancer Center at Columbus, Ohio. And I will be your trusty companion on this journey. These are my disclosures. So by way of outline, I hope to give you all an overview of thyroid cancers and with a discussion of when to consider systemic treatments, what the systemic treatments available are, with pointers for future directions, as well as some take-home points. Coming to our overview of thyroid cancer, so there are an estimated 44,000 new cases a year of thyroid cancer in the US, which constitutes around 2% of all new cases. There are more than 900,000 people in the US today living with thyroid cancer, which tells you a lot about the excellent prognosis associated in the vast majority of folks. Unfortunately, there are more than 2,000 people who do pass away from this disease every year in the US, and it constitutes around 0.5% of all cancer deaths in the US. Coming to the classification of thyroid cancers, they're generally classified as differentiated thyroid cancers, medullary, anaplastic, and some people would also add a fourth category known as poorly differentiated thyroid cancers. I'll be focusing mostly on the differentiated thyroid cancers because they constitute the vast majority, or more than 97% of cases diagnosed every year. There are three main types of differentiated thyroid cancers: papillary, follicular, and Hürthle cell. They usually tend to be treated similarly, so we tend to club them together and we call them differentiated thyroid cancers. And I will have a pointer towards one slide for Hürthle cell and what makes that unique. So what is metastatic thyroid cancer? Cancer that is spread from the thyroid gland by way of lymphatics or blood vessels to other parts of the body, most of the times to the lymph nodes, lungs, or bones, is called metastatic thyroid cancer. Unfortunately, it cannot be cured in some cases, but it can be controlled very well with the treatments that we have. It is important to realize that only 5% of thyroid cases actually become metastatic. So the vast majority of patients are treated with the curative intent. Here's a schematic of thyroid gland. What makes thyroid glands as well as thyroid cancers unique is that they have the ability to take up iodine through a receptor known as the sodium iodide synporter. We use this property to treat these thyroid cancers. One, it is also taken up by the thyroid cancers, and in turn leads to the destruction of the thyroid cancer due to the radioactivity released. There are three main steps in the treatment of differentiated thyroid cancers. Initially, surgery to take out the thyroid as well as the cancer within the thyroid, followed by radioactive iodine, which I just mentioned. And the third and the final step is to suppress the TSH to prevent the thyroid cancer from coming back and to treat any of the micrometastatic disease that is left behind. Now, the vast majority of patients, as I mentioned, are cured with this sequence of three steps of treatment. In a small minority of folks, maybe around 10% or so, Years later, it can present itself with metastatic disease. The treatment at that point is to try radioactive iodine once or more than once to see if we can get the disease back under control. And it works well in shrinking the tumors in around 1 out of 3 cases. Eventually, in 2 out of 3 folks, unfortunately, patients can develop what's called radioactive iodine-refractory disease when the tumors are no longer able to take up and concentrate the radioactive iodine. And we call that RAI-refractory disease. Now, it is important to understand that not all RAI-refractory metastatic thyroid cancers need treatment. For example, here are 2 CAT scans from the chest of a patient who was initially diagnosed with thyroid cancer way back in 2007, and a second CAT scan to the right, which compares it to the disease in 2018, so 11 years later. As you can see, there has been some slow growth in one of the nodules on the left side, and on the right lung, beg your pardon, but it has been very slow over a long course of period of time of over 11 years, which gives us an indication that sometimes these tumors can be very slow growing. And a lot of the times, our indication to treat is initially just to do surveillance with scans and not to rush right away with treatments. So when do we decide to treat or not to treat? We need to consider patient-related factors. So what are your individual goals of treatment? So someone who has is in otherwise really good shape, you like to be aggressive. So we need to individualize this treatment decision to individual patients. Other factors to consider include the health status, age, occupation, medical history, namely, are there any problems with absorption of medications, or high blood pressure, or heart failure, or blood clots, all of which can be an issue when patients are started on treatments, systemic treatments for thyroid cancer. We also need to consider are patients on any other concomitant medications at the same time, which can have interactions, such as certain blood thinners. And finally, we have to ensure that patients have good social and family support and an ability to have high compliance when they start these medications. Now, there are certain tumor-related factors which might compel us to start treatment. For example, if there is tumor in any danger zones, by which I mean, for example, treatment for example, tumor in the brain or in the spinal cord, or near any important structures such as blood vessels or nerves, or a tumor that is impending to cause a fracture. These are tumors that we need to treat right away. Tumors that are also bulky in nature also need to be treated. Tumors that are causing any problematic symptoms need to be treated. If scans show that the tumor is growing quickly with a rapid phase, those also need to be addressed. Or if there's a very rapid rate of rise of the tumor marker thyroglobulin, that is another tumor-related factor that will compel us to start treatments. So we will need to intervene in this situation. So before I go far ahead, I would like to introduce you to a tornado of terminology that's used in clinical trials so that you can better understand some of the data that I will be presenting in the later slides. So clinical trials are divided into 3 phases: phase 1, phase 2, and phase 3, as many of you may be aware. The purpose of a phase 1 study is to confirm safety and to find the right dosage. It usually involves around 20 or 30 patients or so. Medications that have been found to be safe and for which we have found a good dose then move on to what's called a phase 2 trial, where the goal is to confirm the efficacy of the medication and to also confirm safety. Phase 2 trials usually have more patients in them, maybe around 30, 40, or maybe even 100 or so. Once the efficacy and safety has been confirmed in a phase 2 study, then a phase 3 trial is undertaken, which may involve hundreds or sometimes even thousands of patients. And the goal of the phase 3 study at this point is to compare this new treatment to either a standard existing treatment or to a placebo, so that we can get final confirmation about the efficacy and safety of a medicine. And once a medication has gone through these 3 phases of trials is when it's submitted for approval finally by the FDA. When evaluating the response of a medication to the in a clinical trial, there are certain terms that we use, such as complete response, partial response, stable disease, and progressive disease. What it means is complete response is when every known tumor in the body has completely vanished on scans. That's obviously a very, very good response to a treatment. A partial response is when the tumors have shrunk by more than 30% or so, but they are still seen on the scans. Stable disease indicates that the tumors are not progressing, but they've not particularly shrunk in size either. Progressive disease, unfortunately, is when the tumors have become larger or new spots have popped up. There are certain other endpoints that we study in a clinical trial. Progression-free survival is a term, also called PFS. What it means is how long from the start of the study do patients live without the cancer getting worse. It is a surrogate of what we call overall survival, which indicates how long do patients live on the study treatment after they've started the treatment. And finally, objective response rate is what percentage of patients have at least a 30% decrease in size of the tumors in study treatment. So these are terminologies that you will see over and over again when clinical trial results are being described in the literature, especially the objective response rate and the progression-free survival. So in the last decade or so, we have discovered many new targets to treat thyroid cancer, some of which are summarized here in this slide. So all of our normal cells have receptors or projections on the surface of the cells, which act as docking sites or in some cases parking spots for ligands or messengers from the outside. What these ligands do is they dock on the receptors and then they cause downstream signaling, which can lead to the normal growth of the cell. In cancers, what tends to happen is there is unrestricted, unrestrained signaling on these receptors, which leads to excessive stimulation of the pathways, which leads to excessive cell division, leading to what we call a cancer. The goal of the treatments is to essentially tamp down the signaling pathways, either directly or by affecting or inhibiting the receptors which are sitting on the surface of the cell. I have highlighted 4 different types of pathways and medications that we have. One of them is drugs that block the blood supply receptors sitting on the surface of the tumors. There's 3 different medicines which we'll describe today. A second class of treatments is drugs that block the signaling, which happens downstream of these receptors. And we have a signaling pathway known as MAP kinase or MAPK, for which we now have many medications approved for thyroid cancer. Thirdly, there's a group of receptors known as NTRK or RET, also on the surface, which we now have medications to directly target. And finally, there's another growth pathway known as PI3K, for which a medication, everolimus, has been shown to be effective in certain situations. So we are going to go through each of these pathways in a little bit more detail. So initially, the first group of treatments is treatments that target the ability of tumors to grow blood vessels. The more technical term for this is to target the receptor VEGFR. So similar to Tin Man over here, who's lacking blood, the tumors hopefully will also become pale once we start treating with these class of treatments. So there are now no less than 3 medications which have been approved by the FDA, beginning in 2013 with sorafenib, which was essentially the first treatment that we had, which was approved for thyroid cancers. Sorafenib has the ability to shrink the tumors by more than 30% in around 12% of cases, and it can stop the tumors from growing for around a year or so. Now, this breakthrough really has opened us studying multiple different types of treatments in the same family. So lenvatinib was approved in 2015, and it is an extraordinarily efficacious medication for thyroid cancer. Around 2 out of 3 patients have very nice shrinkage when using lenvatinib, and this response on average lasts around 18 months or so for the median person. And much more recently, just last year, a third medication in the same class of treatments, known as cabozantinib, was also approved. Cabozantinib can shrink the tumors in around 15% of the time. But what's interesting is it can even work in folks who have had prior sorafenib and lenvatinib as well. And the effect seems to last for around a year or so. So we have had much progress in this field over the last, I would say, 8 or 9 years. This is an example of a patient who was started on lenvatinib in 2015. On the left side, you can see the scan shows multiple lung nodules or tumors in the lungs. And you can see just 3 months later, there's been a very nice reduction in the amount of tumor in the lungs. And that is also concomitant with a drop in the thyroglobulin, as you can see, from 6,700 to 3,700. So this is a very typical nice response to lenvatinib. In terms of side effects for sorafenib, lenvatinib, and cabozantinib, each of them have certain unique side effects, but they also do have certain side effects that are common or shared among this class of treatments. So sorafenib can cause what's called hand and foot syndrome, which is a crackiness and a redness and soreness of the hands and feet. In addition to that, it can cause diarrhea, skin rashes, some mild fatigue, weight loss, high blood pressure, and mouth sores in around 2 to 10% of patients. Lenvatinib can also cause similar issues with fatigue and mouth sores, hand, foot, and weight loss, again in around 5 to 10%, but is quite well known to increase blood pressure, which can happen in around 40% of patients. So whenever someone is started on lenvatinib, we always recommend that they check their blood pressure very regularly and let us know so that we can titrate blood pressure medicines effectively. Cabozantinib, the recent medication, also has similar side effects with blood pressure, as well as in addition to that, it also can have some mild diarrhea, hand, foot, and mild reduction in appetite and some fatigue as well. This is an example of what a hand-foot reaction to sorafenib looks like. As you can see, there are these blisters on the hands. Usually these are just treated with holding the medication, as well as certain creams which can tamp down the inflammation that you see in this picture. Lenvatinib, in addition, even though it's a highly effective medication, does have side effects. It can cause bleeding in around 1% of patients. It can cause blood clots in around 2%, as well as strokes in 2% of folks. So thankfully, they're rare, but fatal side effects have been seen in around 2% of folks who are on lenvatinib. So just something to keep in mind, especially for folks who have, let's say, a history of a stroke or a history of being prone to bleeding. We always consider whether this medicine is safe, or we even start the medications at lower doses to see if we can do this in a safe and effective fashion. The second class of treatments is treatments that act on the BRAF growth pathway. In patients, it's important to understand that around 50% of patients with papillary thyroid cancer have RAF. The BRAF pathway, when activated by the mutation, becomes sensitive to 2 medicines approved now for thyroid cancer. Specifically, vemurafenib was studied in 2016, and it was found to have a response rate of close to 40% and the ability to keep the tumors from growing on average for around a year and a half or so. This led to further studies, some of which were pioneered by us at Ohio State, particularly this trial, which is a combination of dabrafenib with another medicine called tremetinib, which also acts on the BRAF mutation. This was recently reported, and we also confirmed that the combination can shrink the tumor in around 35 to 40% of patients, and it can keep the cancer at bay for on average around 15 months or so. This is an example of a patient who started on regorafenib in 2017. And as you can see, within a few months of starting the treatment, the large mass that is close to the airway on the left side, and on the picture on the left, has really shrunk by a lot within a few months of starting this treatment. What is interesting to know is that a response on this type of treatment can actually increase the thyroglobulin numbers rather than decrease it, which initially led to a lot of interesting hypotheses. And what we've realized is that these class of treatments actually have the ability to reprogram thyroid cancers. And we'll describe that in a few slides from now. This is another case of a patient who started on the combination of dabrafenib and trametinib on the clinical trial. And you can see that there was a large mass on the right side of the neck on the first picture on the left. And within 8 weeks of treatment, it has really shrunk by a lot. And this patient was on this treatment for close to a year and a half. And similarly to the first case that I highlighted, the thyroglobulin numbers actually went up when the patient had a wonderful response to this treatment. So this idea has led to some more studies. And what we've come to realize over the last decade or so is that medications that target the BRAF and the MEK pathway have this unique ability to reprogram tumors and force the tumors to take up radioactive iodine once more. So as you can see in these pictures, the treatment of a MEK inhibitor, which is a pill by the name of selumetinib, for just 4 weeks, dramatically increased the uptake or the ability of the tumors to take up radioactive iodine in the CAT scan on the right. So this led to a clinical trial that was reported initially in 2013, which showed that around 12 out of 20 patients, when treated with selumetinib, had an increase in the radioactive iodine uptake. Mind you, these patients are all deemed refractory to radioactive iodine in the past. So this was a very nice response to being on the pill for just 4 weeks. Out of those 12 patients, 8 went on to receive another dose of radioactive iodine therapy. And out of those 8, 5 patients had a very nice response. So we call this modality now redifferentiation, or in simpler terms, a resensitization of the tumors to taking up more radioactive iodine. And this has become a mainstay of treatment now for patients who we are starting to see resistant to radioactive iodine. In terms of side effects of this class of medications, it can lead to photosensitivity. Very rarely, some squamous cell skin cancer has also been seen. Mild fatigue, reduced appetite, and weight loss has been reported, as well as some mild joint pains, muscle pains, diarrhea, some liver function abnormalities, and a conduction delay of the heart. So we always recommend that patients get EKGs when they are on this type of medication. The dabrafenib and trametinib combination also has very similar side effects because they are in the same class of category of medication. So skin rashes, lesions can be seen, mild fatigue, and chills. It's important to know that when you start these medications, you can develop a fever. So we recommend patients to have a thermometer and to check the temperatures if they're feeling feverish. Mild joint pains and muscle pains, diarrhea, and nausea have been reported. And it's a good idea to also keep an eye on liver function when you're on these medications. Now, this treatment has recently been approved, the combination of dabrafenib and trametinib, as of just a couple of months ago. It is now available for the treatment of adults and pediatric patients with any metastatic tumor with this mutation, known as the BRAF mutation, who have progressed following prior treatments and have no satisfactory other options. So it's good news for any type of cancer which has a BRAF mutation. The third category is basically medications that target NTRK and RET receptors. So as you can see the scarecrow here, it seems to be a receptor for the crow. Similar to that, we do have certain receptors sitting on the surface of the cancer cell, which act as either kind of projections or docking sites. What we've realized in the last 4 years or so is that two categories of these receptors, one of them known as NTRK, there are 3 types of NTRK receptors, and another category known as RET receptors. When these have activating fusions in the genes that code for these receptors, they are highly sensitive to medications that can target these receptors directly. This is a landmark finding because, yet again, this is an example of what we call precision oncology, wherein we have targeted medications for patients who have targeted genetic alterations in the tumor. So NTRK gene fusions are found in 3% of patients with thyroid cancer, whereas the RET gene fusions occur in around 5 to 7% of patients with thyroid cancer. So in the off chance that your thyroid cancer has these mutations, we now have an entirely new class of treatments which are very safe and effective. So NTRK receptor targeting therapies, we have 2 of them, larotrectinib and entrectinib, both of which were approved in 2018. They were studied in certain trials of thyroid cancer in addition to other types of cancers. Larotrectinib, the first one, was studied in a trial with 28 patients with thyroid cancer. And we found a really stupendous response rate of close to 90% of patients having very nice shrinkage. Entrectinib also has response rates that are quite high, around 50 to 60%. And it seems to be able to hold the cancer at bay for more than 2 years on average. Coming to the second category, known as the RET receptor, there are now 2 medications that are approved in 2020. First one named selpercatinib and the other one named pralsetinib, which were also studied in thyroid cancers and which also have tremendously high response rates of between 80 and 90%. And this has really opened up radically new options for patients who have these genetic fusions in the receptors that I mentioned. Coming to immunotherapy, the role of the immune system is to protect us from infections as well as cancer, similar to the good witch here. And immunotherapy has really radically changed the way we treat many different types of cancers. It's not yet approved for thyroid cancers. It is important to remember this. But we have certain evidence that is emerging that certain types of thyroid cancers may be more sensitive to immunotherapy. So what is immunotherapy? Well, our immune system has what's called checkpoints, or we can think of them as roadblocks that function to slow down and damp down the immune response. This is to prevent runaway inflammation and runaway immune responses. Tumors cleverly learn to hijack these checkpoints or roadblocks, and they in turn damp down immune responses and grow using this property. There are 2 immune checkpoints, PD-L1 or PD-1 and CTLA-4, against which we now have treatments available which have revolutionized the way we treat cancer. So CTLA-4 is a roadblock or a checkpoint that exists in the lymph nodes, which prevents the sentinel cells, dendritic cells, from communicating to the soldier cells, the T cells, thereby allowing the tumors to evade the immune response. Now we have an anti-CTLA-4 antibody now known as ipilimumab, which is very effective in a form of immunotherapy that is approved for many types of cancers. The second checkpoint known as PD-1 which the tumors cleverly cells from attacking the cancer. So we have multiple new treatments available against PD-1, some of which are called pembrolizumab and nivolumab. And now the 2 of these treatments put together are approved for more than 13 different types of cancers. And we are studying them in thyroid cancers as well. Pembrolizumab was initially studied in differentiated thyroid cancers. The response rates were quite modest, though only around 9% or so of patients had a good response. In combination, when you combine nivolumab with ipilimumab, we did find some interesting responses, especially in patients with Hürthle cell, around 30%, and with anaplastic thyroid cancer, also around 30%. The focus of the field now has moved towards combining immunotherapy with the other medications that I've mentioned. So the combination of lenvatinib and pembrolizumab was recently studied, and it showed responses in more than 60% of folks who got the combination, which is an encouraging response. We also have a study that was designed, conducted by Dr. Konda, my colleague here at Ohio State. And the report from this trial is going to be presented next month at the American Thyroid Association's annual meeting. So we will know more about the results from that study. Finally, I did mention that I would talk a little bit about Hürthle cell cancer, which is a type of differentiated thyroid cancer that is on the rarer side. What we've discovered is that Hürthle cell cancers are unique in their genetic profile, in that they have a hyperactive growth pathway known as mTOR or mTOR. And we do have certain medications, namely everolimus, that can target the mTOR growth protein in the tumor. Alliance, which is a cooperative group of many academic institutions, conducted a randomized study, which was phase 2, where we compared the combination of sorafenib with everolimus compared to sorafenib alone. And very intriguingly, we found that progression-free survival was more than doubled with the combination in Hürthle cell cancers. So it is definitely a targeted treatment that is available for Hürthle cell cancers and seems to be quite effective in this situation. I would like to leave you with some take-home messages. As we know, there's no place like home. So let's just recap really quickly from what we've learned so far. Initially, we found that medications that target the VEGFR pathway are very effective in thyroid cancers, and we now have no less than 3 medications in this group of medicines now approved for treatment. Later, we studied that patients who have mutations in the BRAF pathway are very well treated with a combination of either dabrafenib and trametinib or with vemurafenib alone. More recently, we looked at the receptors. When the receptor-driven cancers are activated through gene fusions in mTRK or RET, we now have 4 different treatments that are approved in this situation. And finally, we saw that immunotherapies are now being studied with some emerging evidence of efficacy in certain types of cancers and definitely in combination with the other treatments. I'd like to acknowledge Dr. Konda, my colleague who contributed to this presentation, who, like these ruby red shoes, none of this would be possible without the large group of people that I work with at Ohio State who specialize in thyroid cancers. These are some of them. My colleague, Dr. Konda, this is myself, Dr. Shah, who's an emeritus, pathologists, a large group of endocrinologists, ENT surgeons, thyroid cancer surgeons, clinical trials office, our geneticists, our radiation oncologists, as well as our patients and families. And we also have a large group of our nurses, our research coordinators, and the 2 of us who specialize in thyroid cancers here at Ohio State. And with that, I'd like to end, and I'll open to any questions that you may have.
Excellent, thank you. Looks like we have several questions already in the queue, so I can start reading those. And if anyone listening in still has questions, feel free to type them into the Q&A box. So the first question, when one starts systemic therapy, are the side effects in general such that you cannot continue to work similar to chemotherapy?
No, not at all. And I would say this, I think the first few weeks when you start a systemic treatment are generally the times when we, discover what the side effects you will experience are. It's important to understand not everyone gets all the side effects that are listed on the FDA label. Mm-hmm. The ones that I highlighted usually happen in around 20 to 30% of folks. And usually those side effects you will immediately realize in the first couple of weeks. So our approach here at Ohio State is to see patients back quite often for the first month or so, to make sure that if there are any side effects, we address them appropriately. And usually within that time frame, we're able to get all the side effects under control, and there's no restriction for you going back to work or anything else that you want to do in life when you're on these treatments.
The next question is from Robin. I'm not going to go into all the details she provides, but she's asking, do you have any encouraging words for patients diagnosed with PD-TC RAI-refractory over 12 years ago on many TKIs over the past 10 years? And then she's asking, does immunotherapy and the Lenvima look promising to you more than Lenvima alone, or would you stick to Lenvima, and if that doesn't work, Carbozantab?
Yeah. I think I get the gist of the question. Yeah, the polydifferentiated thyroid cancers are, more challenging in that they can be aggressive. What we've really some evidence is that immunotherapy works better in the more aggressive type of thyroid cancer, such as polydifferentiated. So there's emerging evidence that immunotherapy is a good option. There's a lot of evidence in thyroid cancer as well as in other types of cancers that the combination of lenvatinib and immunotherapy works better than either one of them alone. So we have in anaplastic thyroid cancer, for example, which is an even more aggressive type, there's been very encouraging evidence of excellent differentiators are definitely moving in that direction. I was still we're doing the studies, so we don't yet have the final information. We will know soon as to how effective they are. I did mention the trial, which we are doing. So I would say, yes, immunotherapy is definitely promising in polydifferentiated thyroid cancer. I think holds a lot of promise.
So the next question, are there contradictions with systemic therapy and hypoparathyroidism?
I don't think hypoparathyroidism indication. A lot of our patients have had the parathyroids removed. It's very common. And I don't think hypoparathyroidism, your endocrinologists or your oncologists are keeping an eye on your calcium numbers. There is no problem with you being on a systemic, TKI thyroid treatment that I mentioned. It's just a question of, keeping a close eye on blood work, making sure that you mention if you're starting to develop any kind of neurological symptoms from calcium, so that, your folks can keep a close eye on it. Usually we like to do, calcium, magnesium, any kind of the electrolytes every couple of weeks in the beginning to make sure that you're doing okay on it. Those can go down occasionally. We have seen that happen, but it's definitely, something that can be worked around. It should not prevent you from getting the treatment that you need.
Okay, excellent. The next question, are there benefits to treating metastases like lung nodules early before patients begin to have symptoms?
Yeah, excellent question. I would say this. I think it's a question that we need to do more research about. I know Dr. Wirth and her team at Harvard are actually studying this, looking back at the lenvatinib study and seeing if there was any difference based on the size of the lung nodules, to see if there's any difference in response to the treatments based on how much tumor was in the lungs. So I would say it's still kind of being studied. I will say this, I don't think that the vast majority of folks don't really have any symptoms from the lung nodules. It's important to realize that. Even in the scans that I showed you guys, even with a lot of lung nodules, you don't really get short of breath from that, which is a blessing. So I've never really been in a situation where, there's too much tumor in the lungs that we can't treat with the pills. So our approach has been to be conservative. If there's a few lung nodules, we tend to keep an eye on things. And so far, there is no evidence that folks are harmed, or that there's any evidence that you become symptomatic from doing the conservative thing. So that's been our approach to lung nodules.
Okay. The next question, what is overall survival rate for progressive disease after starting systemic therapy?
Yeah, this is a good question. It actually depends on how many types of treatments you've had, how long you've had your thyroid cancer, and whether you're unlucky and there is some disease in an important organ, let's say the brain or the spinal cord or near a blood vessel. So it's very individualized. It's hard to predict on a case-by-case situation about overall survival. These tumors do become more resistant with time, but we still measure survival in many years, even if you've been on treatments for a long period of time.
Excellent. The next question is, are there contradictions with the Viagra therapies and tumors on blood vessels?
Could you repeat that for a second?
Are there contradictions with Viagra therapies and tumors on blood vessels?
Do you mean VEGF?
Yes, sorry, VEGFR.
Yeah. So the question was, are there contraindications being on that, and if you have blood vessel tumors?
Tumors on blood vessels.
Yeah. This is a very good question, because I would say it is a consideration. If you have tumor that is, let's say, invading a blood vessel, we do have evidence not just in thyroid cancers, but also in kidney cancers and melanomas that you can have life-threatening bleeding in these situations. So that would be an indication in which I would think twice about starting someone on the VEGFR targeted treatments. One way to mitigate the risk would be to try and maybe radiate that tumor to make it shrink a little bit so that it moves away from the blood vessels. So there are different approaches that we can take to reduce the risk of bleeding, but it is definitely something that we think very carefully about before we rush ahead with these kind of treatments.
The next person is asking if there's an optimum time of day to take a TKI like Lenvima to maximize treatment effectiveness but minimize side effects. So maybe at night or the morning.
No, I haven't come across any literature about diurnal variations for side effects. So I think it has to be individualized on a case-to-case basis, right? So I can think of a situation where if someone is having, let's say, some mild diarrhea from the Lenvima, it might be a good idea to kind of take it maybe not to take it right before going to bed, because it might affect your sleep. If you are having issues with blood pressure, it's a good idea to take it at the same time every day, because then you also take the blood pressure medicines along with that. So these are kind of, I would say, common sense approaches, but there's really no hard evidence that taking it at a particular time of the day, either makes it work better or with less side effects. Nothing that I've encountered.
The next question is, if you don't have a mutation analysis and have miliary tumors throughout the lungs, how do you know which drugs to use?
Yeah, is a question that mutation analysis was done and there are no mutations found. I think that's what the question was implying. Yeah, so I would say this: the mutations, it's if you do find an activating mutation, you're just lucky. As I said, other than the BRAF, which is found in 50% of folks, the other ones I mentioned are quite rare. They're seen only in 3 to 7% of folks, specifically the RET and the NTRK. So the vast majority of folks end up starting or being started on one of the VEGFR targeted pills, the Lenvima, the sorafenib, or the cabozantinib. So I would say the vast majority of folks get started on one of those treatments. Now, there is some ongoing controversy about, so let's say you have the BRAF mutation. So what do you start with first, right? Do you start with the BRAF pill or do you start with the VEGF targeted medication? And now we don't actually know the answer to this yet. we need to conduct certain studies where we randomize folks to one half getting one treatment and the other half getting the other, and following patients out. That's, I would say, an active area of research right now. We don't know what the best one to start with is. The good news is both of them seem to be effective regardless, but we don't know if one is superior than the other.
All right. Does RAI-refractive Hürthle cell with no mutations respond to redifferentiation therapy?
Yeah, I think Hürthle cells are really unique, and I try to point that out in that they have a very different genetic profile. They tend to be very hot when you look at them under the FDG PETs. All of these tend to indicate that, they tend to take up the radioactive iodine a little less compared to the other types of thyroid cancer. I think, it's a wonderful question for one of our endocrinologists who specialize in radioactive iodine therapies to see, what their approach has been for titrating radioactive iodine for Hürthle cell patients. I will say, I think unless you have a mutation in the BRAF or the MEK pathway that I mentioned, there is no evidence that, for example, being on the Lenvima makes any difference for radioactive iodine treatment. So the concept of resensitization, or what I call redifferentiation, has been really proven very well in folks who have the BRAF mutations, which tend to be very, very rare, if not, or never really found in the Hürthle cells. So the resensitization concept has been best described for papillary and follicular thyroid patients and not for Hürthle cell. So that is something to keep in mind. But I did point out that there is some evidence that the mTOR pathway inhibitor, the everolimus, is a very good option in these folks. And I also pointed out that immunotherapy seems to work in a good percentage of patients with Hürthle cell. So these are both emerging concepts that I find are very interesting and will need to be studied more.
Okay. Do you recommend the BRAF treatment if it has metastasized into the nodes in the neck?
I think I'll have to look a little bit more into the story. It's a little hard to say. I think the first approach to any cancer is to take it out surgically. So that should be your first approach. If we can take out the neck nodes safely, then we should try to do that. Now, everything else kind of comes after that. So as long as if it's not growing quickly, we can observe. A lot of the times, surveillance is a good option. Now, if surveillance is not a good option, then I think BRAF inhibition is a good treatment, especially if it can be combined with radioactive iodine. So if we can do the resensitization concept that I mentioned, we have started to do that more and more for folks with limited disease to the neck or to the chest. And we tend to preserve some of the VEGF targeted treatments for further down the road. So I think the answer is yes, but it depends on what your particular situation is.
Mm-hmm. Okay, thank you. Is there any clue that BRAF inhibitors drugs like dabrafenib might have improved response rate or length of time of response by combining with immunotherapy?
Yeah, I would say not in thyroid cancers because we're still early in this field. There's extensive evidence in melanoma where the BRAF inhibitors have been studied for maybe 12 plus years at this point. So there are certain studies which have combined BRAF inhibitors with immunotherapy, and they have shown that the combination works better than individually. I think in our case, it's an excellent question. I think we need to design some studies which combine the two modalities to really answer that question. But there's evidence in other types of cancers that that may be the case.
Okay. This individual is asking, is RAI resistance considered poorly differentiated?
I think it's a good question because a lot of my folks also ask me a similar question. So the answer is no. Just because you've had you've developed resistance to the radioactive iodine, it doesn't mean that you have poorly differentiated thyroid cancer. All it means is that the cancers have figured out a way to stop taking up iodine. The term poorly differentiated thyroid cancer essentially is what the pathologists see under the microscope. So it's a microscopic description of what it looks like. It actually doesn't have anything directly to do with radioactive iodine. But I think the gist of the question is, do folks with poorly differentiated thyroid cancer, take up radioactive iodine? And the answer is much, much less so than differentiated thyroid cancer. So, it's right. It's true that if you have poorly differentiated thyroid cancer, the iodine uptake is very less. But it's not true that just because you have iodine-refractory disease that it's become poorly differentiated, if that's clear.
Yeah, that's helpful. Is there any research on why papillary thyroid cancer with RET, which was indolent for 10 years, suddenly becomes active and metastatic? Why does this happen?
Yeah, I would say this, RET fusion-driven thyroid cancers, they tend to be quite slow-growing. And we know that also in medullary thyroid cancer, which has a lot of RET mutations, not fusions. And, prognosis is measured in many decades sometimes. Unfortunately, what tends to happen with cancers is, with time, they just learn to develop resistance to treatments. And they figure out a way to sort of use resources more efficiently and start to grow. This is just the nature of what happens with any cancer with time. It's not, I would say, specific to RET-driven cancers. RET-driven cancers, because overall they are slow-growing thyroid cancers, we see this process develop sometimes over decades. But it's universal to all types of cancers. You just see that happen much more faster in other cancers like lung cancer or colon cancer or breast cancer. But in thyroid cancers, because they tend to be slow growing, thank God, they tend to be slow growing, this process itself may not be very obvious, but it's always happening with time, unfortunately.
Mm-hmm. Okay, looks like we've got just a few more left. In metastatic HCC squarling systemic therapy, would you use lenvatinib together with everolimus, or use one first and then switch at failure?
Wonderful questions. I think I would like to, I think we have to do the standard treatment first. The standard treatment is lenvatinib. So I would start someone on lenvatinib first, because if you look back at the studies, they did include Hürthle cell as well. I mean, anyone with well-differentiated thyroid cancers was eligible for all of those trials. So we do know that they work. The extra piece is what we figured out is that the everolimus seems to have some added benefit in folks with Hürthle cell. So I think I would be very inclined to start someone on lenvatinib, and if I'm starting to see progression, to add on the everolimus to the Lenvima. That's what I would do. I wouldn't necessarily start with the everolimus straight off the bat. I think I would definitely combine it to the most standard treatment, which is Lenvima.
Metastatic Hürthle cell cancer, no mutations, but PD-1 95% on Lenvima for almost 3 years and stable. Do you think immunotherapy should be the next treatment?
Yeah. So somewhat similar to the previous question, I think you really have two options, which are both, I think, exciting. One of them is, seeing if everolimus can be added on to the Lenvima. I would say it's worth remembering that this is off-label treatment, so this is not necessarily an approved way of giving everolimus. But on the flip side, I will say that in renal cell cancer, so in kidney cancers, the combination of Lenvima and everolimus has been studied thoroughly, and so we do know that it is effective, and the side effects are manageable. So it can be done. And the immunotherapy piece, I think, is definitely very encouraging for Hürthle cell. I think combining immunotherapy to Lenvima in this situation would be an excellent second option, if not the combination of the everolimus.
And then what drugs do you try if you don't have genetic analysis of your tumor?
Well, we should try to get the genetic analysis done. I think the bigger question is one of the earlier slides where I talked about how not everyone needs treatments at every juncture. That's very important to understand, is that a lot of the times people can go sometimes for decades with very little disease. Okay, so the first question to ask your doctor is, does my tumor merit treatment right away? And if the answer is yes, then you'll have to ask them, what are the features that compel us to start treatment, and then what are other treatments. So in that case, if your doctor does decide that yes, there are certain reasons for you to start treatment, then I think the next best step would be to try and figure out if the mutations exist. So if there is some disease that can be biopsied, it's a good idea to get it biopsied, because as I've said, if there are certain mutations, it radically changes the treatment options available. It also radically changes the prognosis. So getting the mutation piece figured out as early as possible is very, very vital. A lot of the times, I do see folks in the community sometimes who've had thyroid cancer for a long period of time, metastatic thyroid cancer, without the BRAF testing, which I think really should not be done. We really should need anyone with metastatic disease. If you've been on radioactive iodine once or twice, we need to think about the next steps. And getting a BRAF testing or the extended next generation sequencing is key in that situation. I'm not saying everyone who's had a thyroid cancer needs sequenced, because the vast majority of folks are actually cured with surgery and radioactive iodine. So in a metastatic setting, I would highly encourage everyone to ask their doctors for their BRAF status or the rest of the mutation status. But in folks who have had curative intent treatment, it's not that important.
Okay, well, it looks like we've answered all the questions. One, Barbara submitted a comment that said this has been the best session yet. So thank you so much for sharing your knowledge. And I would echo that. Thank you.
It's very kind of you, Barbara. I appreciate it.
This was a very engaging session. Thank you for volunteering your time and being with us here today.
Yeah. Thank you, everyone. And all the best. Bye-bye.
Thanks.